because a lot of us are new to each other, and so reinforcement is always a good thing. A few introductory comments, and then we'll get right into a rather full agenda. And I'll probably end up saying a few things at the end as wrap-up and a way of teeing up further discussion in July. So if you want to make yourselves comfortable, Vicki, do you have some administrative detail?
Yeah, so for anybody in the room that kept their parking ticket, I would be happy to come around and grab it from you. Just to let you know, this webinar is being recorded. So, and then the mics, the way they work is there's a silver button. It turns red when it's hot. Remember that when you're done talking, to unpush it so that it turns off, and then speak loudly so that it can be recorded and heard later on.
Questions about that? Facilities, just for logistics?
Restrooms are out the door to the right next to the bistro. Okay, great.
And there is a bistro there. So, I'm Rick McCornack. I'm your chair of this august group. Our second meeting today. We're going to get into some technical detail, information that's in your packet, and information that we all need to know. Because what we talk about here is perfectly aligned with all of the accountable communities of health activity going on under the, and influenced by the Medicaid waiver monies that are out there to be demonstrated. So what I'd like to do is to start in the far corner over there. Please introduce yourself by name and the organization you represent.
Remember your mics too.
Thank you, Castle, for the HPW.
John Doyle, Confluence Health in Wenatchee.
Tom Martin, Evergreen Health, Kirkland.
Joe Rozak, Get That Mental Health.
Hi, I'm Carol Dixon with the Port Dallas Ball and Drive.
Federico Cruz with CMAR Community Health. Andrew Nelson, Molina.
I am Joseph Bray with Manhattan.
Keely Davis, off of Manhattan. Keely Klein with HCA.
Mark Province, Healthcare Authority.
Rick McCornack, representing independent physicians through Northwest Physicians Network.
J.D. Fisher, Healthcare Authority.
Frankie Chalmers, pediatrician, Washington,
Jake Fisher, Healthcare Authority. Paul Gable, Coordinated Care.
Tammy Moore, Summit Pacific Medical Center in Greater Harbor County. Don Bonder, Southwest ACH. On the Hospital, Neighborhood Health Services.
Mark Walker, Providence St. Joseph Health.
Hermes Shabazzian, International Community Health Services, King County.
Or Kate Deichman, Healthcare Authority. R.J. Bird, Healthcare Authority.
And do we have any folks on the phone?
Allison Bailey, area Midwest, Michael Duda.
And you folks over in the back row there?
Taylor Down Coordinated Care. Cutler Hay, Community Health Center, Washington. Patty Osborne, America. Lena Nathan, Pierce County ADH.
Brenda Washington State Medical Association. So to get started, today we get into some granular detail. I guess I would like to just say as an opening that three agenda items that we did today. Ask plenty of questions. Not everybody is starting from the same place. We all need to understand the technical issue in roughly the same way. While we're doing that, also keep your other side of your brain open to what I would call the adaptive changes that are offered as an opportunity to work with the Healthier Washington initiatives through the Accountable Communities of Health and Payment Reform, starting with Medicaid. Times are a-changing. Dylan finally got the speech out there, so it's now official. And I would say that the issues that we are going to be talking about around the table for the next several months are immense, because it really, we are addressing issues that the nation is addressing, but we're addressing them in in some granularity with a lot of structure and with a lot of potential money behind it in ways that many other states haven't had that opportunity yet. Forgetting where the East Coast is for a moment and just recognizing where the West Coast is, where we've had much more experience with managed care on the West Coast, particularly in Southern California. And we are now talking about managed care again. We're calling it value-based payment instead. We have to watch our euphemisms here. We're really talking about managed care so that appropriate resources reach the right places at the right time to serve patients. Again, starting with the Medicaid population, which in Washington is continuing to grow. So the two channels I work in are the technical side, which is easy to get into because it's the most concrete, and we'll be doing a lot of that today. The other side is really the adaptive change that has to occur. What are the issues that we're really bumping up against that we might be hesitant to talk about in public, but we certainly talk about openly within our own organizations? What has to happen in the marketplace in order for delivery, systems of delivery to improve both in quality and in cost at a rate that people can tolerate? That's a trick. So picture yourself as a provider, a primary care provider. They're drowning. We know that. They represent 25% of the medical workforce in the nation. 75% of the providers out there are specialists, and they're making anywhere from 2 to 4 or 5 times more in what they do than primary care. And yet primary care is seeing everything for the first time, and it very often doesn't repeat itself in the course of a day. So it's very complicated work. And we're going to complicate it even further because we are wanting integration of behavioral health with physical health. A very complicated proposition, but we're going to do it. It's part of the demonstration. It's one of the first issues up. So there's more stress coming our way, but there's also more dollars coming our way, and I think this table represented presents an opportunity to have varying points of view and experiences and segments of the industry at the table, sometimes dealing with very challenging issues because we're all competing for limited resources. But if we can keep our minds open to the fact that ultimately we aren't really competing for limited resources. We're trying to figure out how to better use the existing resources in the industry so that we're not creating or adding to wasted effort, duplicated effort, redundant effort, effort that isn't really medically or mentally necessary. So that's really what this group can contribute to the ongoing discussions. I think it's going to heat up after this meeting. I think it's going to get very interesting as we get into some really touchy topics. I don't think we're doing our work unless we're really talking about touchy topics, because I think there are a lot of problems to solve from a medical standpoint, from a consumer standpoint, from a management standpoint. And we all know what they are, I think, from our various perspectives. So let's get into it. Let's get into it and ask plenty of questions. This is a chance for you to become engaged. There are no uninformed questions at this table. Everybody has a perspective. If you don't know something that's being talked about, please stop the speaker and say, please inform me what's going on. Mark?
Thanks, Rick. So I'm just going to take a few moments to provide some updates on activities with respect to the demonstration. Forgive me, many of you may know this already, some of you may not, so at the risk of being redundant for some of you, I just want to go over a few highlights. First, as many of you may know, our agreement with the federal government to conduct this 5-year demonstration includes a contract which contains what we refer to as special terms and conditions. That's been negotiated, but it also contains a number of protocols that go into more detail on some of the subjects covered in the SDCs. I'm happy to report that we have received approval from the federal government for, and forgive me, what's called our DSHP claiming protocol. DSHP stands for Designated State Health Programs. It's essentially the protocol that allows us to begin claiming against federal funds. So that's a We are working right now to respond to some CMS questions on a couple of our other protocols that are pertinent to today's discussion, having to do with our project plan. One is our planning protocol. I will note that does not, even though they're asking us to make some changes, those are changes largely in format, not in the focus areas of the projects that we put forward. Those remain the same as they have been. We also are working on what's called the funding and mechanics protocol, which goes into more detail on the ways in which funds flow under the demonstration. I'll note that we've posted protocols on our website, so for those of you wanting some fascinating late night reading, you're welcome to go and read more. I also want to mention that we are working on and have been drafting and will soon post for public comment our project plan template. That is essentially the set of instructions, the guidelines, if you will, for the submission of project proposals by the ACHs to the Healthcare Authority. So that will be posted for public comment June 15th. There'll be about a 15-day public comment period. We're also scheduling a webinar on the project plan template for June 20th. For any of these things, if any of you aren't already on our, I can't remember, do we call it our feedback network? I can't remember. Anyway, if you haven't linked with us, and RJ is nodding her head, so that's good because RJ handles communications. Please sign up for that because that way you'll get announcements from us. Then the final project template is targeted for July 10th. And as a reminder, the ACHs are already beginning to work on their project portfolios, but those project plans will be due to the Healthcare Authority in late October. Also of note, we have a two-phase certification process for the accountable communities of health. All 9 ACHs submitted their phase 1 certification applications to us, and all have passed that milestone. That entitles the ACHs to their first allocation of funds from the demonstration. That's $1 million each. The phase 2 certification process really has begun. There's been conversations, discussions already with the ACHs about what is represented by that. And that phase 2 application template, again, is posted on our website. And that application is due August 14th. And then finally, we have a number of contractors who've already been introduced at our last meeting to at least a couple of our representatives from Manat Health. As a reminder, Manat has the, perhaps some would say unenviable task, others would say the delightful task, it's delightful bit, of working with the ACHs and really helping the ACHs and partnering providers get through this really ambitious period between now and the end of the year for the creation and submission of their project plans, along with the organizational components that each ACH needs to have in place. But in addition to that, we recently contracted with a public consulting group as our financial executor. And as a reminder, the financial executor's role is really to handle the financial transactions really in a centralized accounting and record-keeping way as these funds go from the federal government through us or under our oversight and at the direction of the ACHs out to the partnering providers. So the financial executor will have the role of really managing that traffic. Yeah, Joe?
As the financial executive, will be for that responsibility?
I'm trying to remember what our contract is for the course of 5 years. I can get that information out to you. But it's essentially, it was a procurement, a competitive procurement for a contract, and that contract amount is set and it covers their activities over the course of the 5 years.
I appreciate it.
Okay, sure. Yep, no problem. And we're completing a draft, actually hopefully a final scope of work for the independent assessor, which is another contractor. A procurement will go out for the independent assessor, whose role will be to, as the name implies, review the project plan applications that come in independently of the Healthcare Authority, even though they're a contractor to us. And this responsibility really is to, in a disciplined way, go through those project plan applications, review them for completeness for them, and essentially advise us and advise the ACHs on the success of those project plans. And then subsequently, over the course of the remainder of the demonstration, periodically be involved in reviewing the progress of those project plans. So that's a very important role as well. And then finally, we have we've submitted to the ACHs for review, and are putting final touches on the contract that actually is between the healthcare authority and each ACH, which is a necessary document in order for the funds to flow and for us to know who's accountable for what. So that's my my update. I'm happy to take any additional questions at this point, but I do want to make sure we reserve the bulk of the time for our two main agenda items. So any questions on what I covered? Anybody want to refute anything that I said? Other than my impertinent remark about the unenviable task, I apologize. Anyway, so I'm going to actually turn things over, I think, to JD. Is that right? JD and Emily?
Yeah. Thanks, Mark. I wanted to start off with just thanking everybody in this room for providing the feedback to our team and to Manat about the MCO survey that we released last Friday. We look forward to a similar process and a robust process with the provider-facing version of the survey today and over the next couple weeks. I don't think Emily got a chance to introduce herself, so I want to let you introduce yourself to the group.
Sure, sorry, I left myself on in my front seat. Probably wasn't wise to leave it there. I'm Emily Chester. I am a fairly new 3 months today, I think, Associate Medical Director at Healthcare Authority, and honored to be part of the team and helping to work on this project.
And Emily and I are going to run through the provider survey and where things stand and what we are looking for from this group. And then we're working very closely with Joseph and Haley with the Manat team, and they're going to run through some overviews of the process and expectations moving forward. So just a brief overview of where we are today. As I mentioned, we released the MCO-facing survey last Friday, and that survey will serve multiple purposes. Importantly, serving to give us a baseline for both the 1% withhold in the MCO contracts moving forward, and as well a baseline on a regional basis to under the or perspective of the PPP incentives under the transformation demonstration. So it was very multi-purpose, and it was a very detailed quantitative survey, and we are following a similar process for the provider-facing survey, but are looking to vastly simplify the quantitative portion in order to make it easier to complete, hopefully, and then try to conversely expand a little bit on the qualitative portion, because that's going to be some of the most useful information moving forward into the demonstration and for ACH priorities. So just kind of to frame it up that way. And we're also looking to make that portion of the survey relatively easy to complete, focusing on drop-down menus and multiple choice type questions. So leaving options for open-ended comments and notes, but that's not the crux of the responses. So we're leveraging the same APM categories as we did with the MCO survey, those provided by the federal land framework. I know that group is currently working on an update of that framework, and we're going to continue using the original framework that's also embedded in our contracts, and for the time being stick to that framework. So for the purposes of this survey and this work, we're sticking with the original framework for clarity, and that can still be found on the HCP LAN website. It's not on the, if you go to the APM framework homepage, it'll take you to the updated work. They have some notes and things from their work group sessions, but they still have links up to the original framework, and we're always happy to provide those if you have questions. As I mentioned, we're looking to simplify the quantitative section, so as you review the survey, which I believe went out Monday to this group, we're looking to make sure that that is actually going to accomplish a simplified response process for providers. We're not asking for regional breakouts of the payments received, unlike the regional breakouts we're asking the MCOs to respond to. There's multiple reasons for this. It's a significant degree of difficulty for provider groups to break down their revenue on a regional basis, but also from the standpoint of what we're using this survey for, the most useful information we feel is going to be more of that qualitative information and just general VBP attainment, regardless of the region. Yeah. Yes, thanks. Good question. So I think clinician is a more appropriate term. I apologize for not using that. And we're speaking of billing providers, so including nurses, nurse practitioners, physicians assistants, licensed providers.
If we do have a portion after we go through the survey itself, and I get feedback on whether that wants to be expanded in the survey or not. Yeah. Additional input.
That's behavioral health as well as physical health, obviously.
Absolutely. Yes.
One of my questions was really about the we're always talking about medical providers that have underserved really only one medical
well, mental and we want to include behavioral health as well, but we're not asking for dental services. That would be good to clarify. Yeah, thank you.
I just want to clarify too, so it's right there, supposed to be for mental health, but not dental.
Yes. We haven't, we can provide more. I don't think we have a very detailed description of that as of yet, but that's a good takeaway.
And one more piece of that is, so for the billing providers and including nurses with that, and I don't know if you guys can, billing providers, so, licensing certainly not controllable.
It's appropriate if there's a contract in place for a care coordination agreement, that sort of a process in place, and we are billing for our care coordination. So they should be included in that group. A lot less on the nursing side, but there's occasional. Yeah.
Okay.
Follow-up question. Criteria needs to be clarified, as you see that there are lots of questions, what's in it, what's not in it. So there should be a list of what should be included and what should not be included. Also, the term for the timeline needs to be clarified. Are you looking 12 months, 24 months? What are you looking from beginning, ending? And the dollars here, I'm assuming this is Apple Health dollars, correct? Only.
We're asking for Apple Health, but then we're also asking for Medicare and commercial.
Well, that needs to be clarified also. What type of dollars are you trying to see in this worksheet?
In the table, there's the columns are broken down by the three sectors.
Okay,
but we can make that more explicit.
Yes, and then description or something. What's the purpose of this for your end? Is it to see where dollars are coming from, or which percentage is value-based at this time? So from the payment received perspective, it's to see the level of value-based payment activity in the provider community.
Thanks, fine. But you're sort of saying that we should make sure that this goes out with a clear introduction about what the purpose of the survey is. That you're great. Thank you.
Value-based payment for all payers?
Yes.
Yes.
And it does have those divisions into Medicare, Medicaid, and private insurers.
Employers as well?
One more, can I add
Yeah,
to this?
sure.
I'm just thinking about, I'm looking at the table of this survey, and on the table of disciplines, it doesn't, I mean, some of us have disciplines like dietitians that provide services on the medical floor, so if you really want billable providers that are providing services to medical patients, maybe that's a better way to say it.
Great, thank you. So there's a lot more robust discussion than last time. This is great. Thank you. Yeah.
yeah, all these details are very, very helpful.
Yeah, definitely. So some more about the objectives. As we mentioned, we're looking to see about the level of VBP adoption, and we're asking for calendar year 2016, but also to get more information on readiness and capacity to move forward and to engage in additional alternative payment models and value-based arrangements. This information is going to be really useful for accountable communities of health as they implement their projects under the demonstration. This information will also serve our broader agency goals of tracking VBP adoption and understanding the provider world and understanding how we can support providers moving forward. We understand there's a lot to learn about what providers need and what supports are needed and necessary to move forward and to succeed in this world. And we know that we're not going to succeed in any of our purchasing objectives if providers are not supported and have the tools at their behest to succeed on their own. So we hope to glean information that will help us in that regard as well. And one thing in learning from our last experience last year with the survey of similar nature, it was so complex, I think, that it really was only possible for large systems to respond. And we really want to get at small practices and independent practices and really a broader swath across the state. We got responses primarily from, I-5 corridor large hospital systems, and so particularly under the transformation demonstration and this world of accountable communities of health, it's really important to get a broader response rate from rural providers and smaller providers. So unlike the MCO survey where we had literally a handful of respondents to target, we are going to really lean on this group and other stakeholder groups to get the word out, to promote, to encourage partners to respond. So I think part of our discussion at the end of this portion of the agenda can be around how we can collaborate with this group and promote this survey and boost the response rate. I think that's my question here. Yeah.
If I may, this is really maybe on track and maybe you address it differently, or otherwise, but my big concern is that in the push for value-based purchasing, we obviously are looking at EHR and the vehicle to data collection and data analysis and all that good stuff that goes with it, interoperability. But I want to cross to my colleagues out, outside of the Seattle medical area, is that we don't have a fiber network backbone into the state to support squat. So how do we plan to address that? I mean, I think some people on the island are doing dial-up for crying out loud, and I can push the EHR to the dial-up that I know of. So are you guys going to put in a fiber optic network throughout the state in order to accommodate this endeavor?
Oh, Mark, do we have the funds for that?
Please.
That's a great point, and we have some questions on the qualitative side that get to things of that nature, and I don't think we asked it quite like that, but that's useful feedback.
But yeah, understanding that kind of question of what are the barriers, what are the things that you have to have in order to move forward with this. That is one of the purposes of this, is to gather the scale and scope of that.
Once we know what we're going to do,
we're going to all collectively figure out what we can do.
go to VBP and say, push that fiber out there, right?
Well, I'll lobby Google to get Google Fiber across the state.
I'm with you.
As long as it goes to my house.
Yeah. Are we going to talk later about the method for distribution of this?
Yes, yes.
And actually, one point, Joe, to your question, I think it's a good one, because the other reason for having this kind of dialogue is for us not to assume that there's that connectivity, for example, and then, ascribe less than desired participation to some other reason or something like that. So it's really good to have, even if we can't necessarily solve it by laying all the fiber optic lines, it's important for us to know what's influencing the ability or inability of a provider to engage.
So this is just a snapshot of the high-level overview of the framework that we're using for the template and the way we're defining value-based payments. I think you all have seen this before, but as I mentioned, there is an update coming out to this framework. I'm not sure when the federal group HCP Land plans to release that, but even when they do, we're going to stick with this for the time being. And there's not significant changes to this framework. Really, all it removes Category 2D and adds a Category 4C, at least in the current draft. And the purpose of that is there was a deliberation around, penalties for performance in Category 2 didn't really fit with that category since it was actual risk tied to the contract. So it's kind of lumped into Category 3. And then there was a lot of discussion around integrated finance and delivery systems and how they could stand alone in a population-based system. And so they have added 4C, which will cover those integrated delivery systems. There's also more of an emphasis on appropriateness of care as a measurement and tying reimbursement to appropriateness. So kind of in the bones of the framework and the language around it, they're trying to place more of an emphasis on appropriateness.
I have a question on that.
Sure. Yeah, so for our definitions of value-based payment, we're saying 2C and above. And there are some sticking points about referring to this framework as a continuum. I think it can be described either way. But the point being that some providers and provider groups might fit best in a 2C and don't have the capacity or don't have the patient mix to go to a 3A or a 4B. And that might be just fine, and we don't want to present it such that if you're not in 4B, you're not doing it right. That there's value to all of those subcategories. Yeah. So this is just a snapshot and a screen grab of the quantitative table that we're looking for responses. There are some summary tables that are cut off and to the right, but those are auto-populated and provide totals by sector and by APM subcategory. And as I said, this is not broken down regionally. We're asking for just total revenue in each of these categories and subcategories. I'm going to pass it to Emily to talk about some of the qualitative portion.
As we said, this is sort of built in the same general structure as the MCO survey, but has less complexity in the quantitative part and then sort of more within the qualitative area. So these are the domains of the questions. And the goal here again is to get kind of a snapshot of providers' current level of involvement and their readiness to move forward, and that has sort of both structural components, as you call out, Joe. If you don't have an EMR, and if you don't have the ability to put in an EMR, it's hard to accomplish a lot of these things. We want to understand where people are in terms of data sharing, in terms of IT readiness, also with functionality. How are people looking at things like quality and performance currently, and so how do we think about that in regards to where we're hoping that they'll be able to get to. So we have questions around organization type, ACH participation, general interest in value-based purchasing, barriers and enablers to VBP adoption. I think this is going to be a really interesting one to sort of understand what are the things that are making it easier and harder for people to move down this road. As I said, the IT questions, traditional MCO functions, kind of thinking about the extent to which providers are currently doing some of the things that were kind of once upon a time done mostly by insurance companies, so things like utilization management, is that happening internally? And then also around care management services and integration. There's always a balance between the depth of information that you get from a survey and how possible and likely it is that people will fill it out and send it back. And format plays into that too. So a lot of these are sort of in a drop-down format, so there's the ability to sort of, you see this on the next slide. Apologize for the small print. We expect good vision from people in this process. So there are drop-down menus to kind of allow us to collate the information better, and then the ability for people to give kind of commentary also. So each of the sections has a drop-down menu with answers, and then people can give additional information. Yeah.
I just want to add, I think it's really important to include tribal health clinics or tribal or IHS something.
That is very much appreciated. Thank you for that input. You're absolutely right. Thank you.
And thank you for that. And as you review this, please feel free to suggest additional potential answers for these questions. I tried to slap this together, and I'm far from an expert on the type of provider organizations. So thank you for that, and feel free to add the same suggestions to the rest of the questions.
It's a little bit beyond slapping it together. Let me just be clear. To the extent that people do have the full survey, so it'd be very, very much appreciated if people, as much attention as you can give to that in terms of giving us input into what should be here. So speaking of, yeah.
We were just having a quick discussion here, if you don't mind. It has to do with the behavioral health / substance use disorder facility. I mean, those are essentially redundant in terminology. If we're going to establish a dictionary, which we should, of commonly used definition. Behavioral health, in my world, means mental health and substance use disorder underneath one roof. So you may want to break out another category for a substance use only disorder provider.
And I was thinking along those same lines. So this is facility to me. Is that inpatient? Is that outpatient? Is that if it's a facility? I think of it as an inpatient rather than a clinic.
Okay. So you can think about a different word.
Have a little bit more clarity.
And with that comes the complexity. For example, my agency is a complex agency. We have inpatient, outpatient behavioral health services. So how many, do you want me to check all that apply, or do you want me to find one category that fits me best? I'm not sure how that would work.
It indicates in the question that it's all that applies. So I anticipate for systems like our own that is critical access hospital with cerebral health clinics and behavioral health component, you select all. They should be able to then break out the results.
And I would be clear to understand then that this is going to my partners, so that currently co-locate on my facility, right?
You're answering for them, JD.
Or am I answering for them?
I think we're going to defer that question to a little bit later. The question of sort of under what grouping can people, just decide to report for multiple people at once. So you guys can. We'll be talking about that conversation.
Yeah, that's a discussion point.
Yeah, that's an important discussion point.
I was wondering, so I was wondering about the potential gap of being a potential barrier in access. If there's certain subspecialties or specialties that are not available within your system. If that might not be an area of compromise related.
Let me make sure that I understand. So a gap in the ability to do value-based purchasing,
or actually access to particular medical specialties.
but the gap, so there's clearly a gap for patients in being able to access that, but in terms of VBP, are you thinking in terms of a system not being able to contract in VBP because they don't have all specialties represented?
That's exactly right.
Okay.
And also, or willingness.
Yeah. Yeah.
Which could be a barrier as well. Particularly independence.
Yeah.
You can't get an orthopedic surgeon.
Yeah. It's hard to be responsible for those costs if you can't get those providers involved. Can we reach out, for example, Joe or others, maybe people could identify who would be willing to look at the final organization types that we end up with just to make sure that they feel reflected for you?
My bias? Sure. I mean, I know it's my world. I was trying to say that I have a
yeah, no, I just want to make sure that we get all of those voices.
Yeah, I think someone might have asked this question earlier. How are you defining providers?
Can we just hold that conversation? Because I want to have that conversation. I just didn't think this one for the survey. I think we have a whole conversation about that.
Hard to answer.
No, I understand. This is one of the qualitative questions out of almost about 20, so I think this was put here for example purposes. This was put here also because privatizing is something our just want to have.
I think you have an eager group who's ready to dissect your system. You can get through your orientation of it if you like. That's an eager group is what we want. So some of the kinds of feedback that we are interested in, and as this may be likely an offline discussion since you do have copies of the full survey and this will take more time than we have today, but kind of getting a sense if there are some questions that really feel like this isn't going to be doable for people or this may not be useful information. If you go through the survey and feel as though there are significant gaps and things that we all collectively should be knowing about the baseline that aren't there, thank you. Those are things that we're interested in. Challenges, you know, I anticipate we're going to get different levels of answer from different kinds of providers. So the hospital system is going to have a very different sort of set of answers to clinician practice, and that's okay. I think we need to get a snapshot of all of those as best we can. So there will be variability, but we're interested in any challenges that you anticipate people will have that we might be able to address as we're finalizing this work. Yeah. So your first one on the survey instructions intuitive. If you get, could you just send out the detail where it says total payment? You read that language speaks to premium that a health plan receives. And it talks about exclude your SNAP, your pass-through payments, exclude your wish-up premium, exclude your premium tax premium. I don't think the providers would have any right correlation to that. And then it says, no total payment should represent the total medical premium. Right? Later, it talks about payments, even from an MCO perspective. So we're submitting some of these as an MCO. You may know that already. But I just think there's confusion. Are we talking about premium? Or are we talking about payment? And you're going to especially confuse providers if you have that multiple language in there. Thank you. And when you think about any sort of risk contracts that an MCO might have with a provider, I'll give you one example. If you have a risk-sharing arrangement that's based on, say, a global capitation, it's unclear if along the way maybe a provider is getting some fee-for-service payments, but they've got a pool, a risk pool that they're responsible for. What is payment to them? Right? As an MCO, I'm going to say payment is the global cap that's getting put into their risk pool. As a provider, along the way they're getting fee-for-service payments, and then they're responsible either for a deficit or they're going to get paid out, right, a surplus. How those fit into payment, I think you're going to get perhaps disparate answers from an MCO versus a provider. And I don't think it's even clear how either one of them should fill it out. So you might just want to lay that out in more detail and give a couple of examples. And maybe other MCOs can provide some other scenarios that you can speak to of how they're contracting with providers. So that helps provide that clarity for everybody. Thank you. That's great. That's very much appreciated. Yeah, absolutely.
Go ahead.
I want to make sure that you guys, we sort of go on to the next section, but are there other comments on this section before we move on?
I have take 2 seconds to talk a little bit about, or pause a little bit on the issue of HIT or IT or whatever you want to call it. For the last 12 to 13 years in the Puget Sound area, there's been a lot of thought, a lot of effort to try to figure out whether it's humanly possible to develop an HIE for the complexity of this Puget Sound marketplace, let alone the state. One Health Port was designed architecturally to be able to support HIE functions. What bothers me is that I've been listening to clinicians for 11 or 12 years about data. So the question about HIT or laying optical fiber to pass data, for whose purpose, for whose benefit? Is it for physicians or any clinician, or is it for people who are managing dollars? And I think what I've heard is that the comprehensiveness of information is usually on the administrative side, either plan, hospital, large clinic. It's not on the clinical side, because physicians will tell you, if I'm seeing a patient for the first time coming in from another practice, I'm not particularly interested in what the data say from, a provider I don't know, and I don't know this patient's history. So I'm going to establish that myself. There are some exceptions to that data, like the lab test result that was done 2 days ago. So I think clarification here in the qualitative section of the provider survey, some insights from a clinical perspective, from the variety of clinicians that are being surveyed, would be pretty useful, because I think we confound the different interests in the use of data, and data are very expensive to collect, store, and analyze, and then use. And so I think this is one of those moments where we have an opportunity to gain insight into for whose benefit of the data. I think we have unrealistic expectations if we're thinking about the clinical side, maybe not so much on the administrative side, on the evaluation side, on the money management side.
So I'm going to push back on you about that, because in Southwest I've been meeting with our providers to take that next step to clinical integration. And I've got, a community health, mental health providers, a collection of them that serve 85 to 90% of the Medicaid market, who tell me that they employ somewhere between 4 and 6 full-time staff members whose job it is to do nothing but fax. They stand at a fax machine for 8 hours a day and they fax. And that's without asking them to do integration. And so I've been told that I'm asking them to do something that's just not going to happen until we come up with a way for them to exchange critical sets of data between the primary care physician and the behavioral health practice. They're not all going to be co-located working off the same record. We need some way of enabling them to share critical information if we want them to integrate. And so if we can't come up with a strategy that enables them to do that short of a fax machine, we're really asking them to spin, gold from straw.
You make a really good point, but I think you said the operative phrase there too, which is I'm not too sure we clearly understand what data really need to be.
Well, that needs to be part of our process to establish the data set, the 5 to 7, maybe as many as 10 fields that we need to be able to communicate for a physical health provider to have the necessary information from a behavioral health provider to accomplish integration so that we can actually pay for holistic care.
Right. So in terms of the survey, I think my only question was, is there an opportunity to gain some insight into this, what you described very well?
And what would be the best way to elicit that?
We do have a question on the survey, I believe, that talks about, do you currently exchange information with other providers, and what's the format of that exchange? So I think as we were looking at putting together different qualitative questions, we tried to do it in a quantitative way where there was more checkboxes and free-form text. And if you ever had 1,000 free-form text surveys and tried to make heads or tails out of them, you know that it's almost useless. So we obviously will have missed things, where the review will be very helpful from everybody on whether we have the right checkboxes or not in there. But we do have some things in there that we're trying to get what the current capabilities are, and we really tried to focus on, as a couple slides ago mentioned, these areas. We did look at data sharing as one of the key areas of what currently happens right now in those. We looked at IT readiness, whether they have an EHR, whether they have obviously have EHRs, they don't have care management systems, or they don't have referral management systems. It goes beyond just EHRs as well, and what's potentially necessary.
So is it clear, are they sharing data outside of their EMR environment?
That's one of the questions.
Okay.
How about, do they have an EHR?
That's one of the
Ron, going to your point that you brought up. So two things come to mind. One is, so you're saying that they do have an EHR, but they lack the interoperability. Is that what I heard?
Some have an EHR lack interoperability. There are other providers more broadly in the race region that are still using it.
And that's going to be a whole
other work.
Yeah, and then some, yes. So on top of that, though, is the issue that, especially for behavioral health, we have embedded in our material substance use disorder information along with mental health information. We have to redact information before we can pass it forward to 42 CFR Part 2, which is just, I mean, it's killing my records view. As a matter of fact, if you want to add to a bureaucracy, that's one way to do it, is push this interoperability forward, because I will have to add 5 to 10 people to my records just to every day use whiteout or whatever we can, because we have interoperability. But that's a really critical point. That's going to sway people.
So Samsung is just working on the comments to a rule, so the final rule should be out any day, providing permission for global waiver or global consent waiver from the patient that would free up some of that 42 CFR Part 2 information. That I think we may not necessarily this through, but some combination of folks need to really sit down and chew on and compare to Washington state law and see if that would be a vehicle for us to break free some of that information. Because Samsung recognizes that technology is moving a lot further ahead than the statutes are keeping up with, and it's really becoming a challenge for us to achieve some of these strategies if we've got, locked down information that can't be freed.
If I may, in closing, is that key point that Central also came up with a recent ruling saying that if we transmit SUD information to a primary care physician, they now must be responsible and accountable for that SUD information, the same level of confidentiality that we originally obtained. And a lot of my docs in the area just don't get it. Yeah. Right. So there's an educational component, a foundation that needs to be really solidly established, because otherwise, if you open these floodgates, man, people are going to be doing the walk of shame. It's like, oh boy, HIPAA violations all over the place. That's what I'm concerned about. Thank you.
Yeah, it's not that we don't have data. We have more data than we're even using right now. And then your point of is it's benefiting the administrative side or the clinical side. We take a step back, and I think everyone is here for this reason. We have an opportunity as a state with these dollars to transform healthcare, not to transform delivery of care for Medicaid. And, I'd hate for us to set up a system for how we're going to do this exchange and change culture with our providers with a focus on Medicaid, which should be for all of our patients, and it has applicability there. And so I think the providers I think everyone is right. The providers are frustrated because the data goes for what? Profile me for penalty, or profile me for incentive, or counsel me on clinical transformation, or what? So having it, and it's time to define that for them to help in their mindset change, and not just physicians. I think anyone who's delivering patient-facing care is going to have that same thought process. So I don't know how you try to do it without a free-form text in that regard, but if this is a baseline, we come back again, somehow, we'll have to show what we've done with this, which would include clinical changes for those we serve, but also patients or provider satisfaction in this regard. Because the burnout for them is getting significant, and we're adding to that, which is needed for us to transform the care in the first place. So I don't have the answer. I'm just trying to remind us all that it's an opportunity for transformation.
And as we go through the next discussion about who this should go out to and how it should be delivered, I want to keep that last comment specifically in mind about the burnout. Is something that we've been hearing about quite a bit, about what's being demanded of providers to respond to, and even what the associations and provider outreach are demanding, and what's the appropriate level of what we should be surveying in now, and maybe as one of the requests for comment on PRR is what's the correct length. Are we going too deep on this first survey? Should we be pulling back a little bit? goal with the qualitative questions, I think, is to understand the baseline of where there are needs to improve capacity and help value-based payment in the future. I understand how we take it what you say resonates very well as far as ways different providers will look at it. So when you look at the survey and you look at the list of questions, and if it is too much or if it's too little or there's more other things that we should be looking at instead that would make this both easier to answer and get to a better baseline on where we should be moving the state as a whole. I don't think it's anybody's thought that this is just for Medicaid. I think that we all think that while district funds may be based on Medicaid, that we're not trying to do anything that would be then run differently for any other. So we have it in mind. Whether that comes out clearly or not, I don't know. But.
And I think there's some opportunity, and Emily, you mentioned it earlier, to frame it in an introductory cover letter or email. When we talk a little bit about the deployment of the survey, how it goes out, and the messaging that goes alongside it, I think there's opportunity there too.
Well, I think I mentioned that last meeting, so I'm just really good at beating down horses. But I really do want to caution the group and just all of the efforts about the lack of alignment that's going on around the region. MCOs are out there doing assessments and surveys, and the ACHs have started in various components to reach out and talk to providers and get an idea of what's going on. You've got Qualis out there banging on doors, begging practices to sign up with them to do an assessment. You've got CPI out there banging on doors, getting people to sign up to do assessments and work with them. And this is going to be just another ask of these very same people with a lot of the same requests. But some of the information may be different, but some of this is very similar to what they've already been asked to complete or go through. And I am getting a real sense of not the provider fatigue, but provider annoyance and frustration. So if this is going to be deployed in a way that we want to rely on it as an accurate view of the providers in the region, we've got to get everybody who's out there trying to get this information from providers to the table and agree that, you know, the questions, these will be the questions we'll start with, and they can come in afterwards, maybe do some follow-up, but we've got to get some alignment coordination around the tactical provider for information routine going on.
Great input, and it's actually going to be a great transition to the next part of the fleet.
Well, one thought on the scope of the survey itself is that if you really want clinician provider input, is that there's significant parts of this survey that are going to be done by a provider or a clinician, and maybe you want to think about having separate surveys because a big chunk of this is going to be done by an administrator, and a provider's not going to look at, nor are they going to know the answers. And if you really want a clinician provider practice standpoint, is that you might want to have some more focused questions to get to the kinds of things you were talking about that would be done by a physician or a nurse or a clinician.
I have a question too again about why is Medicaid asking providers how much Medicaid pays them? Like, couldn't you just repopulate the Medicaid piece? Couldn't you pull that data on your own? That's not what MCOs are signed up with. But don't you have a data set that pulls that? Can't you get that?
You know, for example, how much is in a DPP arrangement? You might have a contract with private MCOs. Some of those are going to be DPP in different ways. So how that money is flowing.
We don't have a look into the contract details from an MCO contract.
Proprietary. We don't know. The answer is no.
But it's price attention.
Yeah.
But if we had a single payer system, I'm just saying.
Okay, our work here is done.
Okay. So Don, you brought up a good point about the administration of this survey, and we wanted to have a conversation around that. And before we get into that, we also had a who should get it. So before you can administrate it, you got to figure out should this be limited to providers that are going to enter into an MCO contract, or is there value of looking at the broader provider population that the ACHs are engaging in that may involve community-based organizations or pharmacists or a whole slew of other types of providers out there that could provide services that maybe aren't reimbursed currently, but might be something to get feedback on what they're currently doing, how they're interacting with physical providers, mental health providers, and other organizations. Does it make sense to cast a broader net?
Well, I don't think that would be a different survey. Right, is that what you're, I'm not sure if you're saying that.
Right, this survey wouldn't fit as this.
I don't think this survey would resonate with community-based organizations that I'm working with. I think this would be like Bridge and Andrew. You know, it's not a bad idea to actually think about other cohorts that we would want to survey and actually thought about that. But I would be very concerned about using this one survey across all of the groups and expecting them to actually understand which questions to write NA next to and which questions to actually do them.
I think we should have broader that for sure. I think, you know, we have to think outside of core medical for this, and the social determinant piece is going to have a huge impact on health status, as we all know. Core medical historically has not reached into that portion of the continuum, and so we're not going to be able to own everything, so how do we partner? So to do that, maybe you reach out to the ACHs themselves and their own geographies about how they're trying to organize those community-based resources. Because if they haven't been thinking about it, they really should.
I think if you're talking about the ACH, that's part of that purpose, is to ensure and evaluate where there's duplication of services. So if you do not cast broadband, you are going to miss that opportunity.
I think at least for substance use disorder, probably, in addition to physical health. I don't know how much farther beyond that you want to go.
Well, I guess sort of where my first question started, because I think there's a whole bunch of providers in the public health world. There are nurses that go into the homes that are doing a lot of work with families all over the state, and that would be a group, and that's a significant number of Medicaid dollars that would not be captured in this survey.
Would this survey resonate with them, or would they fall into that probably needing a different tool?
It would resonate with their
And that was
I hear you.
That was a component I was going to mention. When we talk about who's taking the survey, in our facility, our practice is to have that multidisciplinary team. You have executive presence, you have a clinician presence, you have multiple people taking it, and that's what you're going to want to put in your cover letter. Is in an ideal state, you would have multiple representatives at the table to answer that. You learn from each other as well. There's a lot of benefit to that. Then you get that broad perspective.
So I have a question. There's a certain demographic of provider that's actively not taking Medicaid today. They get this survey, they're going to say, I'm just not going to bother. Is that okay? And is that an opportunity that's missed as we think about the load as it's being shared today? So I just don't see an incentive for some independents in particular to respond.
At least not without an incentive to do so.
I'm not sure what there would be that would be incentivized.
That's for providers that don't take Medicaid.
I think there's going to be a likely access issue in parts of
thinking about tools and approaches. I don't think we have any way to force everyone to do it. So trying to do the best we can with the tools that we have. Any thoughts on how we address that beyond maintaining an awareness of who we're getting and sort of thinking about who we're missing and just being aware of that?
Can you incentivize people through PEP providers?
We actually are getting some of the devices
would be able to work. I don't, it's a good thought, but yeah, good thought. I don't know if that's possible or not, but we can look at it.
My guess is that on the physical health side, you'll probably have fairly high success with the large organizations that have the administrative resources to provide the response. I think it's the smaller folks that may just not find it a priority. So I think that voice is important, and I just wonder if maybe you couldn't accomplish that by using a focus group approach. You know, finding 10 or 12 independent practices that are small enough, and just hope that assume that that's going to represent the larger cohort. You could potentially do it regionally, maybe do Eastern Washington, Western Washington, I don't know, something like that. Otherwise, I think you're going to probably get a very low response rate from the independents.
Are you talking independent practices, Andrew?
Yes.
Sorry, Dr. You're talking more small organizations. The thought around critical access use, your collaborative use, any group that you have that would have a larger audience. So like that idea.
You know, we have thought about how to get some similar information. So now that I see this, I can go back and do a little rejiggering of the plans. But part of some of the conversations we've had regionally is I'd like to require providers who want to participate in the incentive program to complete one of these. And if you can't complete the survey, then I got to wonder if you're going to be able to actually keep up and be able to do what we need you to do throughout the 4-year demonstration project, and not to put smaller, more strapped practices in a more uncomfortable position, but to allow for a staff member from the ACH to go over and help them complete the survey if they request assistance, so that it's not an all or nothing. I mean, I thought about it, it's either pay or punish, right? You gotta, that's your stick or your carrot, right? And so if we can attach it to a benefit, I think that opens up the door to allowing more people to figure out a way to get it done and maybe accept assistance, and then to also set the stage, at least at an ACH level, for this is a partnership, and we are going to come in and ask you for information, and we are going to need and require you to be able to help us get the info we need. So let's just start here.
So I think you're reading ahead.
I'm not.
I think one of the things that we put on the slide that is up here right now is our assumption going into the provider survey was that ACH was going to administer this and collect the information back. And the question came up is this better done regionally? And then the next question was, ACHs are required to do provider outreach. Should they have a role in doing this? And then how can we incentivize the providers? So we took all those kind of concepts and we started rolling them together. And we thought that this would be a great group to bring those concepts back to and say, should this be done regionally? Should the ACHs have a broader role? Maybe should the provider survey from the ACH standpoint be a more simplified one that focuses on the numbers, and the one that the ACHs do be the ones more focused on the qualitative answers? Do we then dictate all the questions, or do we say, here's some of the questions that you might want to consider, because them basically tailor it to their own region? I've said a lot. These are all the different questions that we have that we really love to get some feedback from you all on.
First thing I just have is do you have all providers that need to be surveyed, or that could be surveyed? I mean, is there an actual
Why does what you have to go?
No, there's no provider directory.
No, that's what I have, provider directory. There is not. So essentially, even if we did push this out to the ACHs, there's a good risk that they're going to miss a percentage. 5%.
Well, here's what we're going to get. Here's the problem with my idea, because I shut up and then I didn't undercut myself. I'm an attorney by training, so I can argue either side of any argument really well. It makes it really hard to make decisions. But
It'll make it hard to agree.
I don't know if I agree.
We will have, I believe, because I feel like I already have a good amount from working with my partners and the MCOs in my region. I understand who my Medicaid providers are, and I understand who I have who that you need to fill this out or you're not going to be able to participate in the incentive program will connect with. To Tom's point about all those other providers in that next circle, no, I'm not going to know who they are because they're not going to show up in my provider world, and I don't have any incentive for them because they don't want to participate necessarily in the demonstration project because that would mean seeing Medicaid patients. So I think that's a great, I think this is a great strategy for the Medicaid providers and the ACHs to really pull a tight ring for the demonstration project. I do not believe that strategy gets you that broader look at providers in the region overall. And I don't have a good way to get those providers to come to the table and really work on this if they're not seeing Medicaid.
So we came up with, and this moves to the very next slide, on just some concepts on how to potentially incentivize provider participation in this. And again, it's using the district dollars, but this may still have the same issues on that you're bringing up related to will it be more broad or not. But these go from very soft kind of or smaller teeth to bigger teeth. And some of the smaller teeth are just requiring ATHs to do outreach and presentations and webinars in their community about the survey and about filling it out to hopefully drive participation. And then their reporting requirements would be to show us the deck they use, provide, when the webinar was, how many people attended, just provide that kind of documentation that has been done. That would hopefully at least get a reasonable word out, and there'd be some value in that. All the way to, and the last item on this list on is the one that you just talked about. Providers that are participating in these projects can't receive their first dollar or any dollar any foreseeable year if they don't continue to participate in the survey each year. And that's actually a big hit right to the provider then. So that's the big idea. And then we have a number of things in between, such as the thing that's an ACH requirement, and then you're going to have to talk in your year 2 plan about VBP, about what the current state of VBP in your region is. And so you're going to need to get this information. And so we can provide you what we think the survey questions are, but it's your responsibility.
So again, that's all great for providers that are involved in the demonstration. Is there a willingness at the state level to say if you're a provider who sees public employees, you don't fill out the survey, you're no longer included in the panel of providers eligible to see people on the public employee benefits program. Or even all the way down the line to, it's a requirement to keep your license in the state that you fill out a provider survey every 2 years. I'm just, no, I'm sure they're not going to like it. But if you think again about the carrot stick approach, if you can't get them to do it voluntarily, we can, offer to pay them. But seriously, this is a lot of work. I don't think we'd ever come up probably with a budget that would allow compensation that would drive an unwilling party to become a willing party. But there are other levers that we could use if there's a coalition of the willing to. How badly do you want that information?
So longer term, is this going to be the tool to measure whether or not the state met its 90% goal by 2021? Do it through a survey mechanism, or?
No, that's not the goal. And actually, I forget who asked the question at the very beginning. I think, Mark, maybe it was you that said, why are we surveying the providers? What's the overall purpose of this? We're not seeing this as being able to say what the percentages are, because of just how difficult it is to survey individual providers, especially the smaller practices. I think the MCOs are doing reporting. The hard report is going to come from them. That's going to look at that percentage breakdown. This is really to see what resources can be pushed out, continue to be pushed out and developed either through these programs and with district or other programs to help continue to drive the capacity that will support value-based payment features. So it really is looking to give the state and the ACHs and other organizations information that they can use to help further shape and guide their projects and programs. Please start.
I think that's Right, and it actually gets into a little bit of the second agenda item for the meeting, which is the relationship between the VBP activities and the project development. Because in order to know whether the projects as they're designed are also advancing the state's VBP goals, it's important to have some kind of baseline assessment. But to Joseph's point, it's not, it isn't a vehicle for demonstrating year by year whether the state's met its VBP goals.
Well, I guess, I think the last thing you want to do is lose Medicaid providers.
Yeah.
My question is if you know, what's your critical mass number to have a sample to feel like you have a representative understanding of where we are? Because I think that going to more heat is not good.
And actually, one idea, Ron, to respond to your question, it's not so much a number, but it goes back to something Dawn said, and that is, I think we would know that we hadn't met a goal if we did not have at least a significant number of the providers participating in the projects represented in the responses to the survey. And it's a little bit chicken and egg, but that's one way to characterize at least some kind of numerical.
So this is the boil the ocean conundrum, and we always get into this because it's a complex topic. It can go as broadly as we want. Without being overly simplistic, Oregon solved the problem about access by paying efficiently, which made it attractive to see Medicaid patients, even more attractive than seeing commercial patients. So you can go right to the goal if that's the goal. If that's not the goal, you want to do it another way, then you've got more complexity. I guess I have the basic question I'm hearing is, what do we really want to find out? Because we're creeping into broad, complex questions. We have an administrative component which no clinician is going to be able to answer intelligently because they don't look at the billing information in that way. And then you've got the clinical information, which we don't know a whole lot about. And we keep hearing that here too. So what do we really want to learn? And how little could we actually learn that would be really valuable to learn if we learn three things? What would that be?
So I'm trying to ascertain in my region a lowest common denominator understanding of what kind of infrastructure do we need to build, step one, to bring all of our physical health and behavioral health providers to a common landing, so then we can actually start to do the work of integration and some of the other interventions, care coordination, and the other pieces of the project toolkit. Right now, we've got a very unlevel playing field that is really a barrier to asking providers to think about delivering care in a wholly different way from the way they do it now. And we can't even get them to think about what that means from a value-based payment scenario because they really don't understand what it means to integrate, what it means to work with hand-in-hand a physical health provider or vice versa. And we don't have the tools in place to start really letting them get their feet wet on that. So I'm still at that point of, how much money can I take of the pool of money I've got available to me in the short term and say, do I go out and build a regional exchange system, even if it's just based on, direct messaging and buying everybody pre-managed through Eddie? Do I, go out and buy everybody the same EHR? Do I get the hospitals in the area who have Epic to somehow sell Epic to the guys who don't have Epic? I mean, that's the kind of stuff I agree with you, but that's the kind of stuff I'm trying to find a way to ascertain broadly enough to get a sense of, are the dollars coming in the door future even remotely in line with the infrastructure I need to build before I start actually asking these providers to get to the work.
So Dawn, I think there's a lot of reverberation in what you're saying with what's going on in the South Sound right now. And so we can make this really, really difficult, or we can say, and I'll say it again without exposing myself too much, what's our goal? Do we really want people to see Medicaid patients? And if we do, we have to pay them a fair wage to be able to do that, particularly because we're asking them to do things they don't know how to do. And we will be building toolkits and working alongside them over the next few years to help them. But frankly, no one's really nailed this roadmap down. So there's risk. So how much is that worth? Well, right now, it's worth not seeing a Medicaid patient. That's the conclusion you get, because the pay is miserable. It's not sufficient to keep the lights on. In the independent world, actually, and this may be an aberration, they see a disproportionate amount of Medicaid patients compared to the hospital-owned system. What confuses it is that the hospital systems are reporting on inpatient activity. But the ambulatory activity is where they're not carrying the full weight in our data that we see. Now, I don't know whether that's generalizable or not, but again, it goes back to your point. If you're looking at the people who are going to be playing in first phase of being an early adopter and taking risks, there's got to be compensation for that. How do we do that? Is it simple or hard? We're going to make it hard. I think I said too much.
If I can, Don, your point is actually, we're the flip-flop for that, because what you're trying to achieve is clinical integration, because you already got financial integration. We have clinical integration to the nth degree. And
we don't have the financial.
And we don't want the financial integration because we believe it's going to take away from clinical integration, because we've already established clinical integration. So there's a conundrum here of some real challenges, at least from our perspective, that actually we're at loggerheads with the ACA and anybody else who wants to join and stand in front of me on it.
So you're being left, now I can't.
I'm Joe Rozak.
Tell me where you're from.
I'm from Kitsap Mental Health.
Thank you.
And we had the 6 years ago, we had a CMI grant to do behavioral health integration to the nth degree, and we did it in 3 years. We did it to a point that right now CMS is writing research papers on demonstrating on the amount of value and money that has been saved by using our model. But our model now is being torn apart because of the fact that the state's going in a different direction. But that's a whole other day, whole other story. My point is simply is that I hear what you're saying is that I never believed that financial integration was going to drive clinical integration. I believe clinical integration has to come from a different place. It doesn't come from a carrot or a stick. It comes from leadership and motivation of that leadership. We have to provide that vision of why this is important and how that plays to the people we serve. And that's where the difference, I believe, why that came about for us.
Well, and I agree that the financial doesn't drive the clinical, but the financial drives the ability to have a different payment methodology that supports trying to pay at a living wage for these providers across the board. So for us, we now have that financial piece done from a technological and billing standpoint. But now we've got to take that to the next step with the MCOs and say, what is integrated care going to be worth in a value-based methodology, and how do we start to put that together and come up with, the ultimate point Rick is trying to make, which is, can we come up with a number, a payment that allows these Medicaid providers to at least break even? This does not actually make a few dollars at the end of the day. And that's for us, we've got that financial piece in place, we've got the set MCOs, they've got their contracts, they're in place, they're paying for everything. I need to get them to on this other side to get to the integrated place that it sounds like you guys have already.
But if you talk to any MCO who's willing to speak up to that, allow down and step aside, they'll tell you that financial funding that they get is insufficient to meet the needs of the provider. I mean, it's a trickle-down effect of health, is what it amounts to. And we as providers are at the tail end of this thing, and I don't fault the MCOs because they're making the case that their funding is insufficient to actually adequately provide the incentives to the providers from their perspective. So,
well, and to pile on top of that, it's a very difficult position from the ACH's view because we have no field division into the MCO contracts, how they work,
and you won't.
We won't. And yet we're being asked to include value-based payments and moving that along the spectrum and increasing the use of value-based payment without any insight into what are the options, what's being done, what works, what doesn't work. That's all happening outside of the ACH, but yet we're somehow trying to insert ourselves to help move momentum on that. It's just really challenging to have a complete black hole on such a big piece of what's supposed to be driving and pushing the health together.
And we work with the VHO yet, and we have that visibility today. And we'll lose that when we go to underneath MCOs. So, challenging.
I'm not sure we're on the right track.
It's important. I mean, it's all relevant in the background.
I know we have to go on with the agenda, but I guess I want to call out of that a little bit. I mean, I think the reason that we are all talking about value-based payment is the goal, and obviously there are there's a big hump to get over to get there, but the goal that the amount of money that this state has set aside for Medicaid will be able ultimately to be distributed to the people who are doing the critical work of taking care of these patients in a way that is adequate to pay them for their work, and that should come out of money that is culled from the system by moving the flow of funds into the appropriate upstream place where costs are less. I mean, that is the grand vision of this. So I want to first just pull back to that a little bit, and secondly, if we around this table don't have enough detail to understand the vision of kind of how that is working in some places and what it looks like, that may be something that we need to take on as a project, not today, but soon.
Yeah, well, I'm not several people. I'm a friend down on the side of the river that was in the hospital doing okay. Remarkable difference. Organs organized that. Player guard versus that one. There's a lot of money. So, I think the challenge for us is getting into the street. It's not coming. But unless we're honest, open discussion, we're like, you know, have our issue with it, we have to work with the strengths. But it is part of the point.
So, let me do like just wrap this section up, and then we'll get to the next topic. I think we're at that point. Up here is just a timeline, and basically what we're hoping to do is get a survey completed. So, in order to get the survey completed by the 14th, which we're hoping for, we need all the input we can from this group by the 13th. Whether that survey changes remarkably from what we had here or not, I think is maybe an open discussion, and maybe the timelines may change as well. Even if these timelines change, we would like to get feedback on this version of the survey by the 13th so that we can make the appropriate decisions on what needs to happen going forward with all of this as quickly as possible. Maybe I want to add to that.
I have a question about the timeline. Is this just a straw person timeline, or is this a timeline that you really thought through and you're...
After this conversation, I call it more of a straw model.
You know,
Very things trying to hold.
yeah, good. One of my favorites. Thinking about wanting to allow if you're really thinking about the ACHs as a vehicle to drive it is a very, very difficult task. There's vacations and people are short-staffed and nobody appreciates an ask, especially a substantial ask in July and August. If it's meaningful, that's kind of
Don't forget December and then November.
I come from the East Coast. These summers are just other months. So.
So Dave, you want to hear me use that immediately for you?
So.
Great. So shall we take a light stretcher here for about 10, 15 minutes and come back and decide to do the next segment?
Yes, let's be back by 10 till.
How are you doing? John, how are you?
Oh, no.
Yeah, I know, yeah, I
And then we acquired St. Joe's. They're part of Providence Health. Growing pains. The work will grow. Oh, really?
I got what I got.
No, that's really all are. No nonsense.
Sean, I love it. Are you actually talking? Yeah, we have yeah, well, oh, sorry, around there.
Oh, really?
Yeah.
On the river?
Yeah, and we go there every absolute moment. Yeah,
A lot of information. My mother-in-law widowed for well, I'm a happy cherry. You know, water fills up. Your provider, the other provider. But right now, oh, I got another meeting up in Russian.
Ask not for whom to tell.
So we ended up on a high note of energy, and some of that energy is actually going on right now. Is the diet over there? Thank you. There were many threads in the last 15-20 minutes of that conversation, which is really pretty energizing. Do we want to do it? Does anyone else want to put on some of their thoughts on the table now that you've had a couple of minutes to think?
So I just wanted to respond to John's comment about July and August having a good market. And that may be hard for you to engage not to be more involved. I think a bigger part is what you would have to deal with this summer. I think you've got more work than reasonably to have another agency do. But I think it would be a really important thing for the agency to be more involved in engaging other clients around value. So I would like to see that shift focus to the fall. That we don't make a whole lot of sense for the agency.
For the market plan application? That's October.
No.
Well, so what the ACHs are involved in on the ground level this summer and leading up to the fall is a whole lot of work that answers for providers the question of why. It took me a long time to learn this, but you always have to answer that question first, or you'll get very little response.
I don't think the ACH is developing a straight face right now, particularly fully why this is so important. I think you're like a little bit further on the line.
And I do feel I've heard from some of my counterparts via person and electronic means, so I need to make clarification that I am not volunteering all 9 ACHs to do the same work of getting all of this information across all the providers in the state. And we may be very, and this is what I was saying, so if it wasn't clear, I'm glad to have the opportunity to clarify, that we do need a significant portion of the information in this survey, and we will have to find a way to get it anyway, but that really is a very tight connection to Medicaid providers only. Make that clear.
No,
I don't speak for all 9.
And that said, that's the starting place. And from Medicaid, then we move on to other groups of interest.
And I would say the state has, or HCA, I won't speak for any other agency, but HCA has, we're committed to engaging our provider partners through our other programs and our contacts to get other providers engaged. So we wouldn't expect, ACHs to be responsible for that. So I want to make that clear.
You can reach out. Just as a footnote on that, in the Pierce County area, I think 2 months ago, most of the providers in the county had never heard of ACH. I think now more than 50% know what it's about and know kind of where it's going. That's pretty rapid change. The network, communication network, is informal, but it's active, and now that there's a provider committee that's working, the word is out. So I think the timing, like an October timing, would be pretty opportune, I think, to do a survey from that point of view.
Survey just gives you a lot of line time. I mean, what I'm hearing is like I'm starting to work for we did a 300 month for workforce shortages. We just do it 2 times a year. We have to, and the data changes, and people find the answers, some people don't, but at least we're trying to get a good time of what's going
Yeah, I mean, it's very reasonable suggestion.
So is that a pretty good segue to Joseph?
Can you advance the slides? You
Sorry, it was on purpose.
Yeah.
Okay, there we go.
Great. So actually, why don't you do one more? So I just want to tee up this next discussion. So this topic has to do really with the integration of value-based payment with the development of the projects through the ACHs and their provider partners. Really to kind of frame the discussion, this slide really represents kind of from left to right the transition along the 5 years of the demonstration, both in terms of the development along that VBP continuum that JD talked about in terms of that APM framework, that HCP land framework, but also the development of the projects themselves, really leading to, and very importantly, the sustainability of the kinds of Medicaid transformations that we want to put into effect. And so the statement at the top says the shift from fee-for-service to VBP requires delivery system changes. And I'd almost say it works in both directions. The shift along the VBP continuum requires delivery system changes, but I think the kinds of delivery system change opportunities that we introduce with the projects really drives and helps to make that transition possible. And the second statement there is important because it gives some resources behind what we're trying to do, and that's that these funds allow providers to make these changes through initial investments in the transformation process. The idea, again, remember that these demonstration dollars are not service delivery dollars. It's not paying for Medicaid services. It's paying for transformation of the system. And so what we have to think about is the appropriate ways in which we can invest these demonstration dollars to achieve the kinds of delivery system changes that we're seeking. So that's really the point of this slide. And then if you go to the next slide, hopefully you'll recognize these because we sent them out ahead of time, but these are really the two key questions that we thought we wanted you to have in mind through this part of the discussion. How does district funding, and again, forget the acronym, but essentially how do these demonstration dollars for the ACH projects build capabilities that will be important for VBP? So what kinds of investments can be made? How can those investments most easily and readily be made? How can we engage, from the last discussion, providers in being responsive to those kinds of incentives? And then secondly, how will VBP help sustain what's built through the district-funded project? So again, it's not just buying a change over the course of the next 5 years. It's really investing in changes that when the demonstration ends, we have a high degree of confidence that those changes in the system will sustain themselves. And that's a pretty big lift, especially in light of the discussion we had about the adequacy or inadequacy of Medicaid dollars. But face it, folks, the Medicaid dollars are what we have to deal with. I don't think any of us is pretending that we're going to be able to go out and get more Medicaid money. So the real question is, how can we make the investments in ways that are sustainable, that spend the resources we have in a much smarter way, and that assure us that we have some high degree of hope that these things can be sustained over the end of the 5 years. So that's really just the point of these first two slides, and I think at this point I turn it back to Joseph.
Right.
Yeah.
And I really like the way Mark has introduced us. I think that it's really buy into the circular concept where this district or these this project funds do the investments that build capabilities that allow VBP, which will then support it. It's kind of a circular thing. So we really do want you to keep these questions in mind. Our approach that we're going to go through right now is to talk a little bit about the projects that are associated with district and how they're organized. And then we're actually going to pick one of them, I think one of the required ones, 2A, and walk through it. And we'd like, as we're walking through what's involved in that project, to have you start thinking about this and then open up the conversation to delve into these two questions in more detail about what does district think the role of VBP is as we get into this, and what should be included in the project to support VBP, and how will VBP help support sustainability or really, and what the thoughts are there. So, first thing we wanted to do is, Rick, I think that what you just said a little while ago was really enlightening to me that more providers have just learned about this in the last few weeks in the Pierce region than before. And I think that we thought that in this group, maybe not everybody here is familiar with all the different projects and how they're organized and what they're set up. So we wanted to spend a little bit of time talking about them here. The way they're set up is there's 3 different way these projects are set up is they're not individual projects themselves, but they're foundation and components of the other projects. So the funding is specifically divided and related to the other 8 and the selection that each of the ACHs in their regions pick going from there. In this area, the whole financial sustainability through value-based payment is one of those foundation blocks. As you would imagine, workforce is another big component of that, and then systems. You know, those are the things that need to be in place for all of these projects, maybe in different norms and probably different in different regions, but they're going to be foundational and need to be addressed through the different projects above. Domain 2 are about care, delivery, and redesign, and domain 3 is about prevention and health promotion. And the way these 8 projects work is each ACH must do 4 projects. They must do one of the domain 2, which is the integration, the bidirectional integration of care, and they must do one domain 3, which is the opioid use crisis, and then they must do one additional one in each category. So that's a minimum of 4. The way that the funding will work for the ACHs is that there will be potential enhanced funding in district year 1 for ACHs that do more than the minimum of 4 projects. So there could be additional dollars associated with that. And likewise, there might be a little less dollars for one to do less with a whole load of projects. You want to add to that? Okay. Mark said at the very beginning of the meeting, which I know was a really long time ago, but I know the work that's been done, and he mentioned that the project protocol and the project toolkit are in process of being revised with CMS. So what we're giving a sneak peek at here is a little bit of the project toolkit and how we're organizing that to talk about the project. So I'm going to talk structurally about how that is going to be set up, and then David will walk us through the actual project itself. What each project toolkit has is it's going to have an objective, the target population, and then the evidence-based approaches that will support that project going forward. As Mark also mentioned at the beginning, the 8 projects have not changed, their goals have not changed, nothing about the project itself has changed, but the way we're looking at the reporting and how the achievement values are associated with those, how the project toolkit set up has changed slightly. So in the first bit, we have a number of milestones. The milestones have been organized into 3 different stages. The first stage is the planning stage. Technically, we're in the planning stage as part of the plan application, and what we'll be doing is the relevant part of District Year 2 will also be involved in planning. The second stage will be about implementation. We expect that to start in District Year 2 and then continue on through District Year at least 3, potentially into 4, and then stage 3 is basically taking what's been implemented and scaling it and expanding it for sustainability. That may involve changing it as learnings come out as well. For each project, there are a number of defining milestones and then proof of completion of those milestones that must be addressed. As part of the project plan application, we will have minimum dates on when those must be addressed by, and we are expecting the ACHs to respond with what their timeline, their quarter, and the district year that they will complete that will be. And then for each grouping of states, how they plan in a narrative form on addressing meeting those various milestones. Yep, nope, I'm just pausing my screen.
Maybe this is the wrong place, but I struggle with the fact that our statewide flags and our regulatory environment is now we're here for accommodating some of these things that have been pushed forward. Yeah, we run across that before, and I'm just kind of curious if you guys just tell us that, for example, development policy guidelines by the ACH that could actually be in direct conflict with the requirements that we have to abide by as licensing.
So there was a national conference in Denver in April, made up of folks from all around the country, supported 100 different grants, doing this kind of work at different levels. They all had this problem. And over a rather blunt conversation by somebody from an eastern state, the comment was made of keep the lawyers out of the room for as long as possible and make decisions and show your evidence based on practicality, what needs to get done. And they've been fairly successful, and laws have gotten changed. Yes, the laws will always be behind. And I think we're running into this real time, and the volume is increasing. We have laws that were designed for the agricultural age in America. And necessarily, some of that's going to have to change because now we're dealing with Twitter and we're dealing with security issues that are just beyond anybody's comprehension. So I think we just have to assume that that's going to be the case, but push the envelope. The tension here is that everybody's afraid of ending up in an orange suit, and that's real too. So we have to do this responsibly, publicly, in conversation. Invite the lawyers in at the right time.
That sounds fine, good.
I know.
I get audited by
Yes, you do.
the state that actually hangs me by my thumbs.
Yes.
Has done recently because of the fact that I'm not complying with their set practices, their book, and I'm doing the best practices. So I'm kind of struggling here.
So yes, I think we're all probably struggling in our own ways, but I'll just say one more thing about this is that the only way out of this problem, I think, is to have the conversation in public space. You're not alone. And the public space conversation involves the state legislature. It involves attorneys getting it down to what's on paper and what has to change.
I agree. I think it'd be great if we could get not a freeze on, but some sort of, you know, a vehicle or means to allow some flexibility.
Waiver type.
As we reshape this, because we are going to create policy that we haven't thought of yet.
So that can only come through massive suggestion, uniform suggestion about how that gets done. I mean, who invented the laws in the first place?
People trying to accomplish things like that. And now we can move beyond. That's good input, and we do appreciate it. I think one of the things that we've tried to do with the milestones that we've created here is to create some level of standardization between projects. So, kind of brought up around guidelines and policies related to a particular project. It's something that we develop for each of the projects. So it's not the overall policy for everybody in the education what they're doing, but related to this project and how we're implementing it, these are expectations for how we're going to go about it. So each one will have that similar milestone, although the outcomes of that milestone may be very different. Other questions, comments? Gail can take off and play for the next one. The next thing that we wanted to talk about was related to the project metrics themselves. The way that after year one, and I'm sorry if I'm looking too much into the funding mechanics here, but in year one, the payments beyond these two design funds that are going out now and are in process are completely related to the project plan application score and what the APH's maximum value will be. Years 2 through 5 is them achieving specific values. Those values are in milestones, which are part of the P4P, other outcome metrics that, I'm sorry, those people are, and other outcome metrics that are also just reporting only that we expect the APHs and their partners to report on. And then there'll be performance measures as well. And so this next section here that we're showing on this slide starts to talk about, for each district year, we've identified what are the specific reporting metrics that an APH will be responsible for reporting on, which reporting metrics that the state will report on and provide to the APHs. So this isn't a responsibility, but it is information provided to the APHs to help them better manage their projects and the work associated with what they're doing. And then on what time frame that those will be provided. Again, like the milestones, if you achieve a milestone by the quarter that you selected, you'll receive the payment that's associated with that. Similarly, for each of these different reporting metrics, report them based on the time frame that's required, you'll receive that payment. The performance metrics will kick in later in years, district years 3, 4, and 5, and they grow increasingly more important in those years as far as the amount of weight and dollars associated with them. Those will be based on what your actual performance criteria are.
So going to the next slide, we wanted to provide an example of the level and type of information that's in the toolkit for each of the projects. And we focused on the bidirectional integration of care project because this is one of the required projects that each APH will be selecting and implementing in their region. But I wanted to actually just take a step back and clarify perhaps a few things. One, when we talk about the APHs, we're not limiting that to the APH entities.
the legal status ACH entities. And really when we say the ACHs are implementing or doing this work, what we're talking about is all of those partnering providers that make up the ACH. I think that that's really important to remember, because it's not the ACH, it's not just Dawn and her staff trying to develop these guidelines and policies. It is the broader ACH that we're talking about. So I just wanted to bring us all back to that point. The second thing that I wanted to mention is, why do we even have a project toolkit? And I think sometimes the way that the delivery system reform program works, it does feel a little bit clunky. This toolkit is not going to tell you everything you need to know about a successful implementation of bidirectional integration of care. For example, there's nothing here on this page that reflects what Joe had mentioned earlier around what made them successful was really strong leadership, strong vision, and the commitment to do that work. You don't see that reflected here in this document. The toolkit is really structured around, we have this opportunity to invest dollars over the next 5 years, and we needed a structure in how those dollars are earned. And so there are some really generic in how they're phrased sort of milestones across all of the projects of these are the types of milestones that are going to trigger that payment to a region. How payments are earned by a region are not necessarily how those payments are then invested at the regional level. I think that's really important, because there's a more really structured side of it that is the toolkit and is that payment structure that then once the region has earned that, then it's a different type of environment for how you continue to invest those dollars to make sure that you're implementing the project in the region in the way that works for that region and continues to meet the goals of the demonstration, including moving along the value-based payment continuum. So I think there's the toolkit does provide a lot of that structure. It's not going to be the how-to guide to do all of these things in all of the detail that is needed. I'm bringing that up because through a lot of the public comment periods that we've had, it's you're missing these resources, you're missing these implementation partners, you're missing information, and yes, we acknowledge that, but if we tried to put all of that into one document, it'd be thousands and thousands of pages long. So just keep that in mind, that this really is the tool that we are using to define some of the parameters around how dollars are earned through this program, but it's not going to give you everything that you need. So with that kind of reminder, just focusing on this project, what we're talking about here really is that clinical integration side. So we are, for this purpose, we'll set aside the financial integration. There are incentive dollars that can be earned for those regions that are interested in the mid-adopter path, but we'll set that aside for now and just focus on this, the clinical side that is a required project. So for each project, and for this one here, you see, or you can't see because it's probably in very small print, really the project objective, the population, which we are, through the Delivery System Reform Program, we are focusing on our Medicaid population. And then you have evidence-based approaches. The other thing in the development of this toolkit was we only have 5 years, and there was then a strong focus on those evidence-based or promising practices so we weren't completely reinventing the wheel here. And so there is a further requirement here. And in this project that each region is going to be implementing a project, an integration project that includes one approach to integrate both behavioral health into primary care settings and at least one approach to integrate primary care into behavioral health settings. And then you get further into other pieces of the toolkit which provide a little bit greater guidelines around what that implementation needs to look like. Again, it's not going to include everything. Then the other, the next section focus on the different stages that we have divided the 5-year demonstration into. And so we are currently in demonstration year 1, which is really being treated like a ramp-up year. We are still working with CMS on approval of our protocols. Everybody is just really trying to gear up to understand what this is and how we are all going to work together over the next few years. So we focus then on stage 1 as a planning year, and really planning year now we're in demonstration year 2 next year, and we're still doing some planning. And so there will be some key milestones that, if you had just remembered on the page before, or 2 pages ago, on sort of proof of completion, these are the activities that ACHs will be reporting back up to the state, but there's going to be a whole host of work, a whole bunch of work happening below that, that will be really with the ACH and all of their partnering providers. So these are the milestones that are going to be reported up, and will, completion of those triggers those incentive payments. As we move into stage 2, which is implementation of what you've planned for, would be looking at demonstration year 3, when a lot of these activities must be completed by. Now, the way that it's structured is let me make sure my terminology is correct here. We have the timeline. I think it's cut off here, but I think it says, you know, by this date, which means you might have, if you have a region that's doing 8 different, or all 8 projects, that's not to say you can't start implementing sooner if you are prepared to do so. You might have all of your projects on a little bit of a different timeline, but in order to trigger those incentive payments, there are dates by which you must achieve those milestones. Then as we get into demonstration years 4 and 5, that's the stage which we call scale and sustain, which is continuing to either broaden that project, scale it across your region. I think a lot of that will really depend on what you've planned for, and just continuing to then think about the sustainability of the work that you've done once those incentive dollars are no longer available. So those are the main 3 stages, and those are, you would see those in any given project. Again, the milestones will sound very similar across any of the projects. Going to the next slide. The other thing that Joseph has started to mention is those milestones on the first page were really more of those process milestones. There's also project metrics that are attached to each project that, as we get further into the demonstration beginning in year 3, some of those metrics actually turn to pay for performance. And so each project will have a list of those measures that will be reported on and measured for each region to determine whether the outcomes that any region said that they were going to achieve are actually in fact being achieved. So each different metric might transition on a different period as well. So each project will contain that information. And for the most part, for the performance measures, we try to leverage the statewide common measure set to the extent possible. There are a few measures from some more behavioral health measures that are not in the statewide common measure set that came out of the 1519, 5732 set, that those measures are active, and so we wanted to leverage those for this as well. So that's just to give some example of the type of information that's in the toolkit, because then it's important to understand that and think about how are we going to sustain these activities, how does this help the sort of the delivery system reform side, and how does that, I don't want to steal Joseph's thunder because I think he's on the next slide, but how does this support the system to be better positioned for value-based payment?
You mentioned about paper performance happening in year 3. I'm assuming that this can happen sooner, right?
Paper performance, if you're hitting those?
If we're taking it, we can get triggered sooner than right?
Well, there's going to be reporting metrics in the earlier years, so even if you're not hitting it, you're going to trigger it. That vantage point. From the performance measures, if you pick all projects that you already are receiving measures on, there's going to be change in the measures. That's not how that will work. And there's still a negotiation right now as far as how it will work.
A lot of the detail around the actual how you measure performance is
tied up into the funding and mechanics protocol, and that's one that we are still working with CMS on. So, yeah, I think we can.
Any other questions for Taylor about this particular project at all? Please. Thinking about this bidirectional integration, we wanted to go back to Mark's original question, and his question was, how did this funding, the funding that's coming through this project, help build the capacity that will be important for value-based payment going forward? So thinking about what will need to be put in place for this project, how will that support be going forward? And we have some sub-questions here that just kind of hopefully spark the conversation, which is, so what investments will need to be made up front? And will it be private organizations, community-based organizations, generally regional applications? So Don.
We're going to have to make some very targeted investments in training and coaching within the providers on both sides of the spectrum, really hand-holding them through this is how you do it differently and how do you take functions within the office and move them to new types of workforce. You know, how do you really utilize peer coordinators and really get in there. I mean, this isn't something you're going to be able to read a one-pager on and snap your fingers about your practice reform.
Programs that have that operational, you can do video vignettes to actually get that out.
Yeah, but it's going to be a sustained investment to make sure that we're paying for the actual cost of that coaching and training, whether it's virtual or in person, as well as figuring out how to keep practices from actually losing revenue during the process, in which folks are going to have to do training after work and qualify for overtime. We're going to have to help with that. If you're going to take someone out for the day and send them to a session, how do you backfill that person to enable those practices to continue to see patients? I mean, in our region, we already have, you know, a longer wait time than we would like for patients to be seen. The last thing we want to do is slow down that process. So how do we invest to keep practices at as high a level of functioning as we can while keeping them revenue neutral to the greatest extent that we can while we help them with this training and workforce level?
That's most of it. All right,
We have a lot of conversations about the whole issue like interoperability. Most of those that have integrated systems within the whole world, also the whole issue of the working across organizations. And so, and one of the questions is, since this is required of all my regions, is there any thought of doing any either training or looking at system design or potential for help across all 9 regions, as opposed to each region figuring this out, or each ACH figuring this out for themselves? And then the other, sort of like that, along the line of that question.
That's a really great question, and there are several pieces to it, I think. So one element of it is, how many people are aware of the Washington portal? Okay, so this is a provider portal. It's in its infancy. This is developed at the UW under contract with the HCA to provide tools and resources to providers and groups to figure out how to do some of this work. How do you integrate behavioral health into physical medicine? How do you engage as a so-called patient-centered medical home, whether it's a solo practitioner or a group of 55? And by September, I'm told, because I sit on that advisory committee, that by September there will be interactional capabilities on that site, so that you'll actually be able to screen through and filter out stuff you don't want to be reading and get right to what you need to know. And there will be enough material on there, in both in YouTube videos and in other formats, that will teach you And so that is one small component on the provider side of what is becoming available to help people. At the project level, pick a project, pick diabetes. Let's say out of the 9 ACHs, 7 of them decide to focus on diabetes as a chronic condition. And a subcomponent of that may be a behavioral health component like depression. So yes, they need to learn from each other. There's a lot of experience out there. And standards, be quiet. Serious. Just talk about intrusive technology. I know, Google is. But anyway, the opportunity to develop statewide standards through the ACHs, through these projects, is another opportunity I think we ought to be advancing, which goes to your point.
Mark, did you have a point? Could you turn on your mic? Sorry.
I would say, to start off with, as you said, Rick, about keeping the attorneys out of the room, you got to keep the finance people out of the room for this one. Because, you know, everyone's going to be in this room and is going to take back and talk about the value-based approaches, and everyone's going to agree with it, but then they're going to go into an operations improvement plan, and all things are going to be thrown aside. So we have to come up with something pretty concrete. And we're not going to be able to bridge the complete gap from volume to value, but we at least need to have a level of confidence so we instill in them that we're going to get there. So what we have is, you know, as everyone knows, we wouldn't have this system if we threw it all out and then started from scratch. So how do we look at some process improvement and high reliability to look at models of care? Because we do have a provider shortage, but the provider shortage is not as broad as we think it is if we actually had them working at the top of their license right now. And we don't have those skill sets to support them or the process. So patient-centered medical home, behavioral and physical integration for it, but also taking it out and taking the care to where they are versus coming to, you know, our monolith hospitals and, you know, the big flashy neon signs that says clinic is open for 12 hours a day. We need to take it out to them, and we really need to try to let them see that, you know, long-term, because I like the idea of the 5 years, because we all work in one-year budget cycles, but population health transformation will be a 3 to 5 year period by clinicians. And so we have to really ride them, but to do that, they have to buy into this, and they haven't yet. And so that's one. I think the workforce development piece is another for it. We've got to get way upstream. I like the idea of some shared best practices with the ability not to stray and say, I'm just going to be a renegade and not do it, but know that there are local nuances in communities that other communities may not have, you know, and how can they have a little bit of variation in that regard. But in any event, gathering the leaders, because governance is going to be different than management in this regard, by pulling together these multiple tax IDs for the common purpose. And so we have to, I think, stay above that fray and really provide that vision and leadership. Take the bullets, too, along the way.
Good point.
So I just want to circle back and get to the next question on this list, which is what I've been hearing is investments in workforce, investments in training, investments in technology, and standards that maybe cross boundaries, these technologies that cross boundaries between the agencies as potential investments coming out of all this. How do, we have 2 questions at once, how do those support VBP? And then in District Year 6, when there is no visitor funds, will the VBP contracts you're in support the sustainability of those? And what level of VBP and what type of VBP would you have to be involved in order to be self-sustaining?
I think to answer both questions, for me, I think each region is going to have a very serious conversation about how comfortable they are with merging organizations. And that's because certain, when we move in, especially in the higher taxation risk model, you potentially can incentivize the merging of smaller providers into larger systems. And that it's fine and it works in some regions, and that's great. In other regions that are very rural, it does not. And so how can we start that conversation now, and so those rural providers who would like to survive in 5 years and thrive? I mean, we are in a burgeoning system right now, and it's happening across healthcare. It's not just hospitals and healthcare systems, it's insurance companies, it's EHR companies, it's happening across And then what I would want to see in trying to do that as an MCO is, can we structure their improvement in a way that post 2021 we would just sort of be coming in as a different payer for, and I know it's different services and I get it, but like if we're testing home visiting models, which is what people are talking about, your physicians and the CH and everything like that, if we're testing that under the waiver, which is not current, we cover it really with Medicaid, can we give them incentives in a way that we can just model as MCOs afterwards, build it in that structure? And we may not be able to, but if we could start thinking about it from that format, we might be able to come up with some happy medium.
I think
but also I think it's another one of those big lists, just like getting a fiber optic into the state. A lot of these small nonprofit organizations are extremely wedded to their community. And I've seen this happen before where the Forest District refused to consider a merger because it's their service provider. And second thing is that even if you were to go towards a merger, nobody knows how the hell to do it or what to do about it, or how to go about it. They don't never heard about it. I mean, if you get to the business aspect, I think a lot of small organizations and business are prepared for it. That might be another thing that's coming down and have to do with it.
Actually, maybe not. That might be a bad idea. But another element of this from the business side is the consolidation, particularly of hospital systems, always results in higher costs. Is consolidation in this industry advisable?
I would say consolidation, not only higher cost, but lack of innovation. So
Yeah.
I come from a health system that, don't talk to me about merging, because we would lose, and I have partners who might agree, our sense of innovation. We move faster and we are more cutting edge than a lot of organizations have the ability to be because of size and bureaucracy. So I wouldn't be drawn to that.
So if you think about connecting the dots of those last 10 comments, 12, I don't know how many we started with Caitlin, maybe an issue here in terms of value-based payment is from an incentive and sort of structural standpoint, how can the value-based payment system that we end up with in the state, starting with Medicaid, incentivize healthy competition around innovation, around driving toward more value at no increased cost for more people? And not with respect to so-called economies of scale, which are really, it's not a valid notion in healthcare. There is no economy of scale in healthcare. That's been pretty well shown numerically. There are in other industries. So thinking about where we want to end up, I think we begin to shape the flow of that thought process and the resulting incentives, the behavioral incentives, starting now. And this is a very complex and dangerous territory we're getting into, because be careful what you wish for, kind of a thing. There are lots of unintended consequences. And this, I think at this moment, we have to start talking very openly, very candidly, thank you for your start, with the issues that are on the table. Last time I gave you a homework assignment, and some of you have begun listening to An American Sickness. 2 days ago was at Federico, 2 days ago in the New York Times, an issue about specialists. Major policy issue in medicine. It's driving costs and driving needless utilization. Because we're still, I mean, let's talk about elephants in the room. We have a Congress that has a health insurance policy collectively that is unlike any other American person in this country. It's a sweet deal. They don't understand the problems of the industry because they're protected from it themselves. And we here are designing a finance and delivery system as a state in a vacuum, in a tone-deaf nation that really isn't at all coherent on this issue of what we're trying to do in this state. This is a big issue. do it right, we go to Cuba. They have developed a very fine pennies per person. Now, would we want that system? No, of course not. Maybe Denmark, yes. But the point is that we are now in territory where we have to just say anything is permissible to say here at this table. Because otherwise we're not going to advance the envelope and really kind of get outside of our traditional boxes of constraints of what holds us back from saying what is true.
So Rick, I'd like to just offer one thought on that, on the transition from projects to sustainability, right? So I think of the project money as seed money or experimentation money, and I think the key is, as all of the templates point out, are the measurements, and at the end we'll see what worked and what didn't. And then I think the MCOs are then in a position to say, what incentives can we put in the contracts with the providers to sustain those things that we saw worked through the demonstration. So I use our own health plan for, we have 6,000 employees. We made some changes over the last 4 or 5 years, and when some things worked, some things didn't work, but our health costs are back to what they were in 2009 PMPM for 6,000 folks. And so, but we experimented and then we changed the benefit design to those things that worked, and we reinforced those things that did, stop doing those things that didn't seem to make a difference. I mean, I think the key goes back to whatever benefit design or the contract elements that are in place at the end of the experiment that will help sustain those things that work.
I would just add that I think it's important that it's testament to the need for the MCOs to be at the table at least over the next 5 years, so that they're not,
surprised.
Something that they're like, what is that? So I think that
Defining success.
Exactly.
Right.
I can't agree more, Haley. I think that the relationship with the MCO, at least for our experience, has been tremendously impactful. And as we look at the ability to replicate that model, that's going to be key. The missing leg, I guess, of that stool is the legislative component.
Yes.
And so that's that trifecta. That's where we have sustainability.
We're warming up, aren't we? This is good.
Well, remembering that we've made a commitment under the demonstration with respect to the Medicaid cost curve, we've made a commitment to the federal government. We have said that we believe the kinds of things that we're able to invest in will, in essence, keep that curve under control within within a reasonable bound. So that's one way in which to at least get legislative attention. So I think your point's well taken, and that if we're talking sustainability, it's both demonstrating transformations that can be adopted by the MCOs, for example, and built into that system, but also transformations that are that demonstrate to a legislative body that this is actually a reasonable investment and a reasonable ROI.
Yeah.
So I know we have a little bit of time, so about 15 minutes. I don't know how much you want to have at the end around, but
This is part of it.
okay, there is a question I wanted to kind of pick up on, something that you said that I don't think get lost in there. Rick, you mentioned it as well, which is we pay for things that aren't currently paid for, and then we then extend payments to those areas going forward. If we think, and maybe within the bounds of the project we're looking at here, Project 2A, which is that integration of behavioral health and primary care, what's not paid for now that would be beneficial to pay for, to see if it works, to see if we can go and pay for it.
There's aspects of care coordination that are not paid for now, or not paid for in a way that works with the MCO's budget and, what's cost of care versus what's admin. And I know there's been some talk at the state about moving things from one side of the ledger to the other, but that would be one area that would be pretty low-hanging fruit, I think, to start to pick up some of those care coordination services as cost of care rather than administrative expenses. I've heard that as an
So,
issue.
for example, Northwest Physicians Network, 1,000 providers, 8 very well-trained, very expensive nurse and behavioral health case managers. They spend $1 million a year county is moving toward adopting Pathways, which is a cloud-based platform for care coordination. That's going to save money, not only to NPM, but every delivery organization in the county. And it's going to offer open windows to people who are outside the medical delivery system so they can see who's doing what with whom. It's going to save everybody time and money because everybody's working with a Rolodex electronically to figure out who can I call to get such and such a service invoked. So that's a very tangible piece that can be applied to any disease entity or issue entity like opioid use. It's part of the infrastructure, this new infrastructure that we all have to deal with. And how do you pay for that? Well, over time, everybody can pay for that on a PMPM basis or whatever, whether you're the housing authority or whether you're, a hospital system. Because it's not cheap, it doesn't come free, but the software will save everybody money. And ultimately, when hospitals are paid for, not filling beds, but having empty beds, and we get there. This is how you do it.
The complexity is based down to that's already so much clinical and community mental health and care that exists in Medicaid. And I'm sure there are elements of those have some thoughts around what we want to make sure that we pay for. Yeah, it's kind of good. But for what comes to mind immediately for me is community care medicine and how, so that's one of the projects for diversion. It also could be classified as a transition program. It kind of depends on how you want to frame it, but because most EMS districts are public districts, they don't really have infrastructure to bill for Medicaid or are not actual providers, quote unquote. So when we demonstrate the value that they have, and there's some regulations that exist around paramedics also do some of the work that we would like them to do, like all investments in medication reconciliation. Really trying to think of my that we could demonstrate throughout the 5 years, then have that incorporated in the way that we can pay for services. And I don't know the specifics of whether or not what they would do would have to be wrapped into a state plan and then have that approved. I'm not sure if that would continue on through the 15 years that has funding attached. I don't. But that would be a great thing to demonstrate. And if there are multiple regions looking at it, and since it is such an amorphous evidence base, there's a bunch of different models. If we can have some commonality around certain elements of it, it might allow for every region in the future to have something like that as a fire district.
Well, I would feel remiss if I didn't mention the specific subpopulation of those folks that were doing integrated care within the home. And for a significant number of those that are not in housing or that we're trying to get into housing, there's no way to pay for management services for those, but they require a huge amount of case management. About 40% of our homeless population that we work with have a mental health related or behavioral health related condition, and they require intensive services. Our ratio is about 1 to 10, and for many of those, there's no way to cover the case management services separate from care coordination.
Francie, did you have a comment that you were making?
Well, I guess it's a little bit tangential, but I think if we look at the foundation of this whole system as being the primary care workforce, we are really at risk of losing a lot of that workforce if we can't bring the basic reimbursement up to Medicare parity. And that's actually not a huge amount of money. It's an annual cost. But I started thinking in the very early stages of thinking about Medicaid, oh, I'm gonna do these great things, and I don't get that Medicare parity. But I'm realizing that's not at all the case. I'm going to hire people to help me do the more valuable care and reduce costs in the future for the state. It's not going to come back to me as extra money to cover my cost of providing primary care. And so without somehow fixing that problem, I don't see how all this work is going to be sustainable. We'll develop some great projects, and they'll be covered, during and the project may be sustainable. But if you don't fix the problem of the primary care physicians or nurse practitioners being compensated at least Medicare parity, which will cover costs, they're not going to be around to keep implementing the project.
Two thoughts in response to that, which is, I think, a really valuable point. One is that if you approach it from a little bit of a different perspective, perhaps, and think about how can you have the opportunity to manage more of the resources that are available in a way that does make sense, not only for the addition of staff and other resources that help you manage the patients, but that compensate adequately for the time that you spend. And to somebody's earlier point, kind of working at the top of your practice. So I think it's and that's part of, I think, what this whole group is doing as we kind of break away from our tendency to think about encounter-based reimbursement and the low, relatively low level of payment, per encounter. The other thought is, through another set of activities under our SIM grant, we have been working on alternative payment models for primary care, specifically with federally qualified health centers and rural health clinics. But I think some of those concepts may help to inform some of the discussion here, and at some point perhaps we can bring some of that information back to the group.
And I think that's great. I'm also looking at that. I think so we do need to look at the cost of providing the in-the-clinic care for at the primary care level. And those visits aren't going to go away. The volume for primary care is not going to go drastically down. We can become more efficient in how we see those patients. We can, perhaps reallocate costs. But if we want to improve well child care, we're going to have more visits. If we want to do immunizations, we're going to have more interactions, not fewer.
I do think that the goal is, and Bob and I had this conversation a day or two ago, of sort of you can't say even we'll give you $4 more per patient per month, but you're spending $5 more per patient per month on staffing. And the goal, and it will be complicated to get there, but is that the reimbursement will be higher. And is that measured through a per patient per visit way? Probably not. Does that involve reallocation ultimately of resources away from a cardiologist because you're a pediatrician, so this is a good example for you. But for me, if I prevent a patient from having a heart attack because I've got the case management and the resources to make sure that his diabetes is well controlled and his blood pressure is well controlled, and that money does flow back. So I just want to push back against the idea that the savings here are just designed to go to the state and the practices will be carrying more and more load. That's the whole goal of this, I think, is to feed the resources into the right place so that you have those resources.
And I have two responses to that. One is I've heard from other parts of the country that have tried that the money doesn't trickle down to primary care. And also that if we're looking at even having a 1% withhold from the 50% that's already been withheld, that's not sustainable. So to have a withhold taken away with the hopes of having a gain a year and a half later is not going to be sustainable for a lot of providers. And it would be, I would love for what you're saying to be absolutely true, but I don't think that's been portrayed to providers as realistic.
So in a way,
we've got to try to make
these two positions that you and Mark have kind of outlined here really are kind of the crosshairs of a very big complex issue we have to solve. If you don't have primary care at the table, and they have the ability to say, no, I'm not going to see any Medicaid patients, in our world, in my world, that's not an option. But it clearly is around the state, an option not to take Medicaid. Well, if payment...
So it's not to take Medicaid or close your door.
Well, yeah, right. But 75% of Medicare. And there are primary care docs in Oregon who are doing very nicely, thank you. And they are filling their panels with Medicaid patients. Now, you don't want to go so far that you created another problem too. So,
Well, if you take that money from
yeah. So it's a both and, and I think we're going to be. This is kind of teeing up because we are getting to closing time. Teeing up our next discussion in July. Mark sent out 2 questions that really are part of this last 20 minutes of discussion here. I would recommend to all of you, if you have the time, 5 minutes in private. Think about what your answers are to questions 1 and 2 that Mark sent out yesterday. These are good questions. I think they are a follow-on to this, and I think it's the beginning of next meeting. To get into, let's think about the role of value-based payment, where we're going with it, what our recommendations are going to be, and how it fits into the larger picture of what's getting now on the ground through the ACHs and through structures, program structures that have incentive dollars to pay for that activity. We want it to be sustainable. What are those issues that we're going to recommend that are going to make it sustainable? There are many pieces to it. We need to start thinking about it now. So I think this discussion, this group, is moving rapidly into contested terrain, and it's wonderful. This is the sort of conversation we've been needing to have in this state for a long time. Thank you, HTA and others, for getting us there. This is a good way to do it. We have virtually all perspectives of the industry at the table in big buckets, and it's our problem to solve. There are no winners and losers here. It's kind of figuring out how to do the quilt differently.
Last time I asked these 2 questions, I want to ask them again because they're very helpful to us. Really quickly, if anybody's willing to volunteer, what worked for you in this meeting? What was helpful, positive? Was there anything that resonated in terms of something you liked? And the flip side, what could we do better? Are there things that you'd improve? So if anyone has anything to say on either one of those questions, that would be great to hear. You're all still awake. I'm going to put that in the plus category. So.
I'll start off. Number 1 is I am very appreciative of the openness of this opportunity to hear diverse opinions and being accepting and not judgmental on that. I think that's really, really helpful. Instead of people getting shut down or closed down or saying, yeah, we've always done it that way. So I really appreciate that a lot. Number 2 is I really appreciate the diversity of opinions that came out of this discussion. I found it quite enlightening. And now we're getting into the devil or God in the details of that goes. But I agree with you, Ray. I think that we are definitely moving to that point where we need to be for some time. And since the HCA is allowing that to happen rather than having things happen behind closed doors, we're doing this out in the open. And it's like sausage being made. It's not pretty, but it's definitely viable now.
Thanks.
I second.
So, rules of the road. Thanks for those comments, and we'll try to keep it there. This is a group effort. Anything is permissible to say here. This is not personal. This is system stuff, tough stuff. And so the tone, I think, is where we want to stay. And we've kind of found our sweet spot in 2 meetings. That's pretty rapid progress. We want to keep it in that space. Again, this is a democracy. It ain't going to be perfection 100%, first time out the chute, but we certainly want to be in the right ball field. And we want to be in a different place than we are in 2017. Because where we are today ain't good for anybody, for any of us. It's not a healthy workplace for any of us. It's not a healthy place to be a patient. Long term, we want to make a better world. We can do it. And I think we can do it through this forum, working with the ACH forums as well. So please consider these two questions. I'm plugging Mark's questions because I think they're right on the mark for teaming up where we start next time in July. Schedule.
Next meeting is, is it, who's got the clicker? Can you advance the slide? I think.
July.
Yeah, there we go. So next meeting scheduled for Tuesday, July 18th. That's going to be a morning meeting. And Missy, was there anything else we needed to say about that at this point? I know we've been working on venues. I know, thank you for those of you who did respond. Missy did send out a poll. Of course, we did not get unanimous approval for any one particular location, so we're just going to have to do our best to meet your needs. Anything else that you can think of?
We don't have a place.
Do we have a venue nailed down for the 18th? Which is?
Regional Center up in Seattle. It is close to the ferry. If you go to, I can send out.
We can send, yeah, we'll send the link.
Well, thanks everyone. This has been I think a really rewarding 3-hour discussion. So thanks for your contribution. We'll see you next time.